I want to try to keep this fairly short today because I want us to have time to do the case and also go through. I want Jill, our information specialist, to sort of walk you through the website a little bit as well. So I'm going to try to shorten this up a little bit more. Than the slides will be in there if you want to look at them, but we're not going to go through all of them. Okay. That's all right. You want me to try them? So the same goals we've had before with all these different drugs. This is our fourth and final really combination agent that we wanted to talk about. And again, the goals are the same. Review the mechanisms of action, look at the summary of some of the major characteristics of the drug, and then review some of the clinical data that led to the approval of this particular combination. Sorry, which one? I always hit the wrong one. There we go. So again, you've seen the slide enough now. This particular combination, elbasovir, grisopavir, is a combination of an NS3/4A, part of this replication complex, the one down, second one from the purple, and an NS5A, which is that green one. So those are the two enzymes that's blocking, these two drugs block, to inhibit the viral replication. And here's our summary table, and this particular one is elbasovir, grisopavir. It's the fourth one down. And as you can see, I think one important thing you're going to keep in mind with this particular agent is it only works against genotypes 1 and 4, so it is not a pangenotypic agent. And it also, in certain cases, needs to be combined with an older drug called ribavirin, which we'll talk a little bit about as well. Okay. And again, if anybody has questions going through this, please stop and we'll talk about whatever comes up, okay? So this is, again, more of salvage stuff that I'm not going to go through with you guys, but it's here just so you can look at it. So Zepotir was approved in 2016. It's elbasovir is the NS5A portion, grisopavir is the NS3/4A. It's 1 tablet a day with or without food, and similar to Mavyret, it is not, you can't use it for child PU class B or C liver disease, and again, that's really because of the NS3/4A, the grisopavir. Rarely those NS3/4A agents can cause drug-induced hepatitis, so if you've got decompensated cirrhosis, they recommend you stay away from these kind of agents. It's got about a 10% risk of headache, fatigue, or nausea. But honestly, like everything so far, I really haven't, and I don't know if Jen has, had anybody stop it for side effects yet. Okay. Important drug interactions for rifampin is a big one. A lot of the HIV drugs, but hopefully you guys won't have to deal with that yourselves. I think it's important to know that the level of the drug decreases with CYP3A, 3/4A inducers, particularly things like Dilatin, Tegretol, and again, efavirenz is one of the HIV drugs. And you do get some INR fluctuations, so you got to watch it if people are on Coumadin with this drug. So once again, always look for the drug interactions. So I'm not going to belabor this slide, but basically, Zepotir is approved for genotypes 1 and genotype 4. And we'll go through some of the clinical trials that led to that approval. And as you notice, sometimes you have to go 16 weeks, and we'll get into why that is too. So it's one of the least expensive drugs. I know it's hard to believe at 12 weeks, $26,000 is one of the cheapest. I think it in Mavyret for 8 weeks is about $26,400, so they're pretty close. But if you go to 16 weeks, then you're up around $35,000. Again, I don't know what's going to happen next year, but as far as I know, this drug's not going to come down in price. I haven't heard it is anyway. Do you know anything about it, Yi, or no? No. So to go to the clinical trials, this one was the EDGE naive trial. It was for genotypes 1, 4, and 6. And basically it included patients with compensated cirrhosis and patients without cirrhosis. And basically they had a placebo arm for 12 weeks, and they were allowed to cross over after that and be treated, which is what they did. And so it was 3 different genotypes with or without compensated cirrhosis. And so what they found was that for the most part, they had fairly good success with the exception of genotype 6. Now, admittedly, there were only 10 patients in that group, but they only got an 80% cure rate with genotype 6. Genotypes 1 and 4, they did really well with. And again, we'll get into a little bit of specifics. Though this is the one drug where 1A and 1B matters, as opposed to the other drugs we talk about. And you'll see that here in a little bit. So this just breaks it out between those who had cirrhosis and those who didn't. And again, we're talking compensated cirrhosis, meaning Child-Pugh class A. Again, it worked really well with patients with cirrhosis, and really the viral load difference between less than 800,000, greater than 800,000 wasn't statistically significant. So these authors concluded that it was okay for 1, 4, and 6. It turns out really 6 is not, it's not approved for 6 because if you saw there was only 80% in the 10 people, and there are other trials that came out, and I think we'll touch on a couple of those that also show that 6, it just doesn't work as well for 6. And by the way, at some point, I would like us to talk about, maybe in one of these future ones, why there are genotypes. It's kind of interesting evolutionarily why hepatitis C has different genotypes, and that could be a separate little discussion for later, but I just want to throw that out, that that's kind of a fun thing that maybe we can talk about coming up. Okay.
Probably Adirondacks who might not have a huge amount of experience, but certainly have the right outlook on things. Some are physicians, some are administrative people.
Do we have somebody with a question?
Don't know.
Okay. Well, now we don't.
Okay. So here's another trial where they were looking. Notice they didn't even try to use 3. They knew it was going to. This was not a genotype 3 drugs. They were going for 2, 4, 5, and 6. And again, if I remember correctly, this included those with and without cirrhosis. And basically, it was a little bit different here because they also had an arm that just had grisopavir in it for genotype 2, if I remember. Yeah, it was genotype 2. No, it is non-cirrhotic. I'm sorry. This was just non-cirrhotic patients. Okay. What did I do wrong? Oh, there we go.
Nothing.
So,
Didn't do anything wrong.
lo and behold, it doesn't work well against genotype 2, and it doesn't work well against genotype 6. Genotype 5, I think it was questionable, but again, the numbers were really small. And I think that's part of the problem is when you get into these unusual genotypes around, it's really hard to get enough patients in a trial to really know what you've got. But it's clear here that genotypes 2 and 6 aren't so good. Okay. So they said genotype 6. I don't really think that's true myself, and evidently the people that the FDA didn't think so either because they only approved it for 1 and 4. So we're going to skip the treatment experience stuff. Like I said, I want to get you guys to the case more than this stuff. We don't need to talk about all the treatment experience people. I'm sorry if I'm making anybody dizzy. But you're welcome to look at this stuff. But this is all for treatment experienced people, and I think that's more our job on our end than you guys having to treat treatment experienced patients. So I'm going to keep skipping. Okay, so to sum up what I think is the important things about this particular drug is, it is once a day pill with or without food. It's well tolerated. Again, we haven't had anybody stop it for side effects. And then importantly, this really is helpful. Even if you're on dialysis, this drug can be used. As long as you don't have a Child-Pugh class B or C, this is a great drug for people on dialysis. If they have the right genotype, obviously. And its downside is just that. It's not a pangenotypic agent. It's only been FDA approved for types 1 and 4. It's not, like all these drugs, it's still a lot of money. $30,000 for 12 weeks is a lot of money. And if you have genotype 1A, you have to do something called pre-treatment NS5A resistance testing. And I didn't get into that with you guys in the clinical trials, but it turns out if you have to do this thing called an NS5A resistance test, which is a blood test. And we actually have it at our site for you to see how to order it.
Oh, yeah.
And it's about 1 in 10 people that have genotype 1A will have pre-existing resistance to the elbasovir. That's the drug that's resistant to. And if you have that pre-existing resistance, then you have to combine, if you're going to use Zephyr, you have to combine it with ribavirin and treat for 16 weeks, not 12. So you're having to add a drug that has some fair number of its own issues, that is an older drug. And when you have to add ribavirin, you have to worry about the fact that people get anemic on it. You have to draw their blood every couple of weeks. And it is also a teratogenic agent. It can cause neural tube defects. And men and women both need to use 2 forms of birth control that are sexually active. And they need to continue to do that even 9 months post-treatment, because ribavirin can be excreted in semen even 9 months out. And so this applies to men too. It's not just women. If you have to use ribavirin, then they have to use 2 forms of birth control and practice 2 forms of birth control even 9 months post-treatment. In fact, we make people, when we have to use ribavirin, we have a form that we make them sign saying that they're going to do just that, and that we've discussed that with them. So that's really kind of, in my mind, the biggest downside of Zepatier is that for at least 1A, and again, about 70% of the people in the United States have 1A, hepatitis C. Oh, okay. You really, that's kind of a big downside if you have to test all your 1As and then add ribavirin to some of them. So that's its biggest problem. And I think with that, I've talked to you about the child PBRC. You can't use it for decompensated cirrhosis. And there's, again, the drug interactions. So for all those reasons, I think this is we definitely use this drug. If you have a genotype 1B, it's great. And they don't have, decompensated liver disease. And it is one of the least expensive. So you probably will wind up using it, but there's a lot of caveats to it. And I think if you're having to use ribavirin, you're usually better off using one of our other agents, unless the insurance makes you use this. And that's becoming less and less common now, where they make us use Zepatier, thank goodness. Okay, that's all I wanted to say. Anybody have any questions?
So just bear with me here, folks. I am going to...
Hopefully we won't have to go out and intubate Ashley. She's coughing.
Yeah. I don't know. Just give us a minute and we'll, if anybody has any questions, we'll be with you here in just a second. Oops. So I'm going to stop sharing.